The broadcast is now starting. All attendees are in listen-only mode.
Good evening, and thank you for joining the RLS Foundation's webinar, Augmentation and RLS. My name is Zibby Crawford, and I'm the Marketing Coordinator at the Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Bookführer will answer as many questions as time allows after his presentation. After the webinar, you will receive an email with a link to the webinar recording. The recording will also be made available in the members only section of our website. If you are not a Foundation member and would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. Our speaker today is Dr. Mark Bookführer. He is a consulting assistant professor at the Stanford School of Medicine. He's a certified RLS expert and teaches sleep medicine to doctors training at the Stanford Sleep Medicine Center RLS Clinic, a member of the RLS Foundation's Quality Care Center network. He is board certified in sleep medicine, pulmonary disease, and internal medicine. Dr. Bookführer, we thank you for sharing your time and your expertise with us today, and I now invite you to begin your presentation.
Okay, thank you very much, Zibby. And today we're going to go over augmentation. We'll discuss what it is, what we can do about it, and more importantly, how to avoid it. So we'll head up to our first slide. So what exactly is augmentation? Well, very simple way to understand it. It's a worsening of RLS after initial improvement with a dopamine medication. And I've listed the typical dopamine medications that we use. Levodopa is actually a precursor of dopamine, so it's a little different than the other ones. But the two most common ones of the short-acting are the pramipexole or Mirapex and ropinirole or Roquip, although both of these come in a long-acting form. The rotigotine or Nupro patch is a 24-hour form. And there's another drug that we don't really use very much called cabergoline, which is a drug that actually has a 64-hour half-life, so it lasts a few days, but it's not approved for restless legs or even Parkinson's disease here in the United States, so we don't have too much experience. In Europe, it's approved for Parkinson's, so they have used it quite a bit for restless legs. Now, the only other non-dopamine type drug that can cause augmentation is the drug called tramadol. The brand name is Ultram. And this is a pain pill somewhat related to the opioids. Not sure if it's a true opioid, but this is the only other pill that can cause it. All the other drugs that are used for restless legs, like the gabapentin type drugs and Lyrica and Horizon, do not cause augmentation. All the other opioids do not cause augmentation. So it's only this tramadol and the dopamine drugs. So when was augmentation first described? A lot of people think that this is something that we just learned about recently. We actually knew about it a few years before. I saw my first patient in augmentation in 1991, but the first article that came out was written by Richard Allen and the group at Hopkins in 1996. So, you know, we're many years after that, and still a lot of doctors don't understand or even know about augmentation. And their paper was the augmentation of restless leg syndrome with Sinemet or carbidopa-levodopa. And they found that this augmentation occurred in 82% of patients on that drug. It was worse with the higher doses, and it was resolved by stopping or decreasing the medication. We have the first set of criteria that was developed in 2003, and this is a criteria I use. There's other ones I'll show you in a minute, but this is a simple one. What they described was a worsening of restless leg symptoms after starting dopamine agonist, that's DA therapy, or tramadol, usually months to years after starting it. they saw an earlier onset of symptoms by at least 2 hours. So if initially the person had it at 10 p.m., they would get it at 8 p.m. or 7 or 6. There was an increase in intensity of symptoms compared to previous before therapy. There was a quicker onset of symptoms as rest. The person could not sit as long or be sedentary without getting symptoms. And the medication effect didn't last as long. Also, there's a spread of symptoms to other body parts, typically the arms first, but it can go to any and every body part. And I've seen many patients with it in just about every body part you can mention. The other thing is something called the PLMW, and those are periodic limb movements, but the W stands for while awake. So this may occur for the first time or get worse. So a very simple thing I try to teach the training sleep doctors or anyone, instead of remembering all the things I just talked about, whenever a patient who has been on a stable treatment, on a dopamine drug or Ultram, for at least 6 months requests more medication, it is restless legs unless proven otherwise. You want to rule out some other conditions. And one is medications that worsen restless legs. And most of you know the whole slew of medications and probably have the RLS medical alert card that lists all the medications such as Benadryl and antidepressants that may worsen restless legs. We look for low iron levels. If the person has had some problems with iron deficiency anemia that's worsened, it could trigger worsening restless legs without being augmentation. We look for comorbid conditions. This means other conditions that are associated with restless legs. The iron deficiency is actually one of them, but pregnancy and kidney failure, and there's a whole bunch of other more minor ones, but these are the big ones that may cause a worsening of restless legs, again, without being augmentation. Change in lifestyle. I've had a patient who was a supervisor, like floor supervisor, having to walk around, and he was doing that for many years, had no daytime trouble with his restless legs. He was doing such a good job. He was kicked upstairs to a desk job, and then his RLS went crazy. He couldn't understand it. We talked about it, and he realized, hey, this desk job is killing him. He actually went to his bosses and said he doesn't care if he gets a decrease in pay. He wants to go back to his floor supervisor job, and that fixed the problem without any change in medication or calling it augmentation. The other thing we see is patients who have increased stress, anxiety, or depression. That can sometimes provoke worsening RLS. Very difficult because sometimes the worsening RLS can provoke these issues. So we sometimes can't figure out which is the chicken and the egg here. The other issue we have, and is the patient who's worsening getting augmentation, or just is this a natural worsening of restless legs? And this is the big problem why many of the other fairly reasonable specialists, but sleep specialists or neurologists, but who are not one of the kind of national restless leg specialists, have trouble differentiating. And that's why they often just increase the medication, figuring, well, the medication worked, the patient is getting a little worse, their RLS must just be naturally getting worse, and they don't twig that it's restless legs. So here's the interesting thing. The augmentation gets worse with an increase in the dose. So if you look back and say, oh yeah, I keep giving the patient medication to get better, but each time they keep getting worse with time, the trouble is it may take months or years. So unless you look back and say, oh yeah, this has been going on over the last few years, you may not realize that this is what's going on. And sometimes patients go to different doctors, and each doctor may not review the previous medication that well. The other problem is that the augmentation gets better when you decrease or especially eliminate the medication. This can happen within a few days with levodopa, so it can be very obvious, but we don't use much Cinemet these days. However, unfortunately, it can take several weeks or sometimes months with the dopamine agonists, and most patients will be suffering as you decrease the dose, so most doctors won't be patient enough to wait. So what exactly causes this augmentation problem? We don't know for sure. But here's one of our best theories. Listed over here under where it says DA are the 3 dopamine agonists that are approved for restless legs and that we use commonly: the propenolol, rotigine. And what you see here is their affinity for the D or dopamine subreceptors. There are 5 dopamine subreceptors, and what you can see with all 3 of these, they hit the D3 the most. And the D3, any medication that hits the D3 receptor will give the majority of patients significant RLS relief. But they all hit the D1 receptors, which you can see are on the far right, the least. And what we think happens here is because of this imbalance of stimulating the D3, but not the D1 receptor, the D1 receptor starts to become more active. And we found that increased activity of the D1 receptor makes RLS worse. And the other interesting thing is when you get rid of the dopamine agonist, you can reset that D1 receptor and the RLS becomes a lot easier to control. So how common is augmentation? Well, you saw in the article in 1996 by Richard Allen from Hopkins, they found 82% of the patients developed this augmentation. We have some newer articles now, and with Mirapex, which is pramipexole, we now have several articles which average about 7 to 8% per year. That means at 10 years, 70 to 80% of the patients will have augmentation. Now, again, if I told anyone, any doctor, any patient, hey, I'll give you this treatment, it'll make you well, but in 10 years, you have a 70 to 80% chance it'll make your disease worse, I don't think many people would want to try this medication. The Nupro patch seems to have a little less issues with augmentation. It's longer acting, and we believe the percent that people get augmentation is related to the how long acting the medication is. With the longer acting one, it's better. So we see only 5% after 5 years with the approved doses of 1 to 3 milligrams of the Nupro patch. And our theory is that it may be less common with longer acting dopamine agonists. Actually, before I do this, let me just say, however, we're not sure because one of the first and easiest signs to pick up augmentation is an earlier onset of symptoms. So if you're treating with a 24-hour drug, you may be masking it and kicking this down the road. We don't know. It's kind of interesting, but we do see people do better. And I will often add, if I have to, a low dose of Nupro, which may be very helpful. And as long as I keep the dose low, possibly in combination with other medications, we may not get augmentation. But you can get augmentation even at very low doses of any of these drugs. The other thing that we're seeing now with doctors like myself, who are one of the national restless leg experts, way over 75% of the referrals or cases we see are augmentation cases. So, these drugs, Mirapex and Requip, have been around for more than 10 years. So we're getting that 70, 80% of patients worse. So it is a virtual epidemic of augmentation now. And unfortunately, most of the other doctors aren't that aware of what to do. So people like myself are often getting deluged with these patients. So what are the recommended doses of these dopamine agonists? For pramipexole, patients should be started on 0.125 per day if you're going to use these medications. I rarely see a patient who started on that low a dose. They're usually started on 0.25 or higher. The maximum recommended dose, according to the articles, is one of the articles that we've actually written. We use 0.75 because that's what's approved in Europe, but in the United States, it's actually only 0.5. And I'll give you my doses in a little bit. The ropinirole or Equip should start at 0.25. Again, I rarely see that. And a max of 4 milligrams is approved. The rotigotine or Nupro patch is 1 milligram per day initial dose. And on a weekly basis, you can increase up to 3 milligrams per day if needed. So what are my maximum doses? For the pramipexole or Mirapex, I say if you get to 0.25, that's as high as you should go. I see patients on 10 or 20 times that dose, not infrequently. The ropinirole or Equip 1 milligram, I have seen patients on just recently on 16 milligrams, and I had one physician, their patient, that they would go up to for even 48 milligrams on that. The reticotine or Nupro patch, the approved dose is 3 milligrams, and that's one I agree with. I think that's reasonable, but the 1 or 2 are even better. However, I see people on 8 milligrams of the Nupro patch, often in addition to ropinirole and or pramipexole. So what do most doctors, including other specialists, do? As I said before, they see a patient with the augmentation, and what they typically will do is increase the dopamine drug, and patients will get temporary relief, sometimes even up to a few years or longer. So it looks like they're doing the right thing, and when the patient comes back, they just say, hey, your RLS is just worsening, we'll keep doing that. So, and as I said, I've seen doses of Mirapex up to 8 milligrams. We talked about the ropinirole and the Nupro. So sometimes they'll even add gabapentin to these patients, which may be a little helpful to not increase the dose, but typically they're missing the boat on what to do. So because of that, in 2016, a bunch of us got together and we published the first consensus paper called the Guidelines for the First-Line Treatment of Restless Legs, Prevention and Treatment of Dopaminergic Augmentation. And we had people from all over the world working on this together. So the first thing we'll talk about is preventing augmentation. That's pretty simple. Don't treat, treat initially with a non-dopaminergic drug, and you can't cause augmentation. Of course, you include Ultram or Tramadol with that. But unfortunately, you have to consider the risks and benefits of all the treatments, and sometimes doing that may not be appropriate or not available. The one thing I will caution everybody, because I see this all the time, if you're on one short-acting dopamine agonist, such as Mirapex or Equip, and that causes augmentation, do not change to another one. Doctors love to do this, and it is absolutely positively predictable that sooner or later, usually sooner, the augmentation will come back. So if you have to be on a dopamine drug, what do? The first thing is you want to keep the dopamine dose as low as possible. Still can happen, but you reduce the risk. So you don't want to exceed the daily recommendations. And here I'm putting for Mirapex 0.5, not even 0.75, Requip 4 milligrams, and reticotine 3 milligrams. Probably even better to use my upper limits, which are much lower than these. Consider adding a non-dopamine drug instead of increasing the dose when patients are not doing well. These are the things I'm advising other doctors and patients to follow or to suggest to their doctor. The other thing is you don't need to eliminate 100% of the RLS symptoms. Sometimes patients say, I don't ever want to feel any of these symptoms. I think it's important to eliminate close to 100% of the RLS symptoms at bedtime so the patients can sleep. But in the daytime, when patients have options to move around, work, do housework, go shopping, whatever, you don't have to necessarily eliminate all the symptoms. You do want to eliminate the disruptive symptoms. And now intermittent treatment can work and not cause augmentation. Even levodopa, which is the most common drug that causes RLS the most readily, up to 3 times a week, it cannot cause augmentation. The longer-acting dopamine agonists, as we said before, does it cause less augmentation or does it mask it? We're not sure. But even with these drugs, we really try hard to use the lowest effective dose. The other thing is keeping your serum iron or ferritin levels high. Ferritin levels over 50 to 75 have been associated with less augmentation, low levels of these with more augmentation. So I'm going to go over the augmentation treatment algorithm, which is in the paper, and I think you can find this on the website also. And of course, you can see this is a very simple thing, so you can look at it for about 10 seconds. I'm sure you can all remember this completely. Just kidding here. I'm going to go over one by one so that you'll see it actually is fairly simple. So the first thing is you want to eliminate exacerbating factors. You want to get the iron levels up, the ferritin as we see on the left, lifestyle changes, exacerbating drugs, and things like that. We talked about that before. So we define augmentation as either mild or severe on the left yellow box. Mild augmentation has to have all the below. A temporal shift mainly, which is a shift of 2 hours or more earlier. The dopamine drug has not exceeded the maximum dose recommended. The symptoms just cause mild distress, and there has been no prior increases above whatever dose was first established to be effective. So if you have a patient on, let's say, 0.25 of Mirapex, there's been no increases since then, since you established that as an effective dose. On the right, you see severe augmentation. It's whatever is not mild, or patients who do not respond to the treatment for mild augmentation, which I'm going to go over now. So the first goal is keep that dopamine agonist dose the same. Try not to increase it. And we have two options here. One is you can split the dose. So for example, if the patient's on 0.25 milligrams of Mirapex, cut that pill in half and give 0.125 as you were probably doing late, near bedtime, an hour before bedtime or so, and give the other dose about an hour before the symptoms are coming. So if you have symptoms earlier at 7 p.m., give it at 6. The other thing is you can just take the whole dose and give it earlier. The issue with that is with the short-acting dopamine agonists, they may not last long and you may get breakthrough symptoms in the middle of the night. And they say consider increasing the dose if they fail. But what you'll hear me say over and over is once you start having these problems, it is much easier to tackle it earlier than later. So I would bite the bullet earlier than later, but we still give an option of increasing the dose once. So if that strategy fails, you think of a complete switch of medication. And we have two options here. The first thing is what I said before, switching earlier than later is a very, very good idea. Much easier on the patient and the doctor because you'll have a better chance of success. Again, easier and much less stressful on both of us. You have two choices, the alpha-2 delta drugs, which are gabapentin, Horizont, and Lyrica, and the long-acting dopamine agonists. We'll start first with the alpha-2 delta drugs. Here's a list of them. We have the gabapentin and acarbal or Horizont on top, which is approved, and the pregabalin and gabapentin, which are not. And I'll give you quickly my dose recommendations. So for gabapentin and acarbal, which is Horizont, if patients are under 65, I'll typically start at 600 milligrams. And if they're older, both biologically and chronologically, I may fudge a little bit there. I'll use the renal dose, which is 300 milligrams. The usual daily dose is between 600 and 1200 milligrams, although only the 600 is approved for restless legs. Then we have the pregabalin or Lyrica. For younger patients, I'll start at 75 milligrams, 50 for older patients, and I'll usually increase this dose every 5 to 7 days by the initial dose. Usual doses are between 150 and 450 milligrams per day, usually taken in the evening, a couple hours before bedtime. Gabapentin, also not approved for restless legs, but inexpensive, so easy to get. My younger patients, I'll start with 300 milligrams, the older ones with 100, and I'll increase by the initial dose, again, every 5 to 7 days. I will caution that higher doses of this typically don't get absorbed. So some people may absorb it well, you can try it, but most people, once they get above 600 to 900 milligrams on a dose, are unlikely to get more benefit. So what about the long-acting dopamine agonist? It's much easier than switching to an alpha-2 delta drug because when you remove the dopamine agonist, the RLS starts to go a little crazy, and sometimes the alpha-2 delta drugs are not up to treating that as they would be if you saw a patient who'd never got any medication and you're just starting therapy. We have two drugs to consider, and I'll show you how we make the changes here. So if you're using pramipexole, and you want to change to the rotigotine patch, which is the first column. From 0.25, I would go to the 2 milligram patch. From 0.5 or higher, I go to the 3 milligram patch. You want to change to pramipexole E, which is not sometimes hard to get. You see the equivalent dose changes. I don't do that too often. I mostly will use the rotigotine patch. And for ropinirole, if you're on 0.5 milligram to 1 milligram, the 2 milligram patch for rotigotine, a little higher dose for the, or a little different dose for the pramipexole, and for ropinirole 2 milligrams or higher, the 3 milligram patch. That's as high as we want to go. The trouble is, as you'll see for severe augmentation in a minute, we have patients on much, much higher doses than that, so there's really no equivalent change. So if these strategies fail, we now have a patient in severe augmentation. And for severe augmentation, the goal is to at least reduce, sometimes that helps, but my goal is typically get rid of the short-acting dopamine agonist and treat with something else. So I'll give you some of the strategies that we have now. We have a cross titration, and what that means is very similar to what we talked about before. You want to add an alpha-2 delta drug and then slowly decrease and or reduce the dopamine agonist, with the objective of either getting it down or eliminating it. I can tell you for my severe patients, this is rarely successful because they're on such high doses that as you decrease the dopamine drug, the alpha-2 delta drug just doesn't seem to do enough. So this is one of the things we can suggest better for the milder cases, and that's why I say try to bite the bullet earlier. You'll have a chance of success with this. With the more severe patients, this is going to be tough. The other one is switch the patient from a short-acting dopamine agonist to a long-acting if they're not already on it. The issue here is, again, most of these patients are on such high doses that I don't want to put them on a high dose of a long-acting because we'll get augmentation. The next one is called the 10-day washout. This was developed by Johns Hopkins. They have actually changed this more recently to a 12-day washout. And what they do is they have the patient stop the drug, well, first taper off the drug, and then additionally stop it for 10 to 12 days. And then they can evaluate where the patient is. The benefit of this is some patients may not need as heavy-duty medications, as I'll describe in a minute, but the majority probably still go on and need the next therapy, which I'll describe. And the trouble is, for much of the taper period and total withdrawal period from drugs, they may not sleep at all. So this can be quite stressful, again, for both patients and the doctors trying to get them through this. So the last strategy, the one we tend to use a lot for these severe patients, is to consider opioid therapy. And we use oxycodone or methadone. I typically start with methadone because, for reasons we're not fully aware, probably 70% plus or minus of the patients we treat do better with methadone than any other drug. And with the methadone, we can usually make the transition from even high doses of a dopamine agonist to completely off the dopamine agonist being not very painful, if at all. The other thing we want to do is make sure the iron levels are good, and if appropriate, we will treat with intravenous iron. If available, and that could be done in some places. It's very difficult, but if that could be done, that can sometimes be very, very helpful. So just remember, preventing augmentation is much easier than treating it. So I tell patients and physicians, avoid starting short-acting dopamine agonists unless there are compelling reasons. I teach the sleep fellows that are training that don't start Mirapex or Equip unless, again, you have no other choices, whether it's financial or otherwise, but I really try to stay away from those medications. Again, no one I know would like to start a medication that, after 10 years and we're treating a long-term illness, will have a 70-80% chance of making you worse. And when these are prescribed, these short-acting dopamine agonists, try to keep the dose as low as possible. You saw my upper limit of the Mirapex is 0.25, and for Requip, 1 milligram, much lower than recommended. Doses recommended the limit, keep them even lower if you can. And what I think is, for a new patient, unless there's reasons otherwise, I would start with an alpha-2 delta drug, gabapentin, Horizon, or Lyrica, or possibly, if those are contraindicated, a long-acting dopamine agonist like the Nupro patch. And if the patient isn't doing well with one of those drugs, add the other class. Again, try to stay away from the short-acting drugs. If necessary, we then add opioids. So if you and your doctors follow my advice, we will hopefully see a marked decrease in augmentation and keep the many, or actually not too many of us national restless leg specialists not as busy with augmentation as we have been. So that's the talk for now, and I'll be happy to answer questions.
All right, thanks very much. These are questions that were submitted with registration. So, do most people have RLS symptoms in upper parts of the body, or just people with augmentation? I have it in all extremities.
Okay, so typically RLS has to start in the legs first. Sometimes it can go to other body parts and actually leave the legs, but it must have started in the legs. The most common change of RLS symptoms to the arms or other body parts are in the augmented patients, but you will sometimes see this with patients who just slowly develop more severe augmentations, treated or not treated over time. I still say the majority of people I see with RLS first goes to the arms, but then it can go to any and every body part, typically are augmented patients.
All right. Can augmentation occur with even the smallest doses of Requip?
Unfortunately, they can. It is a dose-related phenomena, so the higher the dose, the more likely. But unfortunately, I've seen it with the lowest dose of Requip, even at the 0.25 milligrams, and even the lowest dose of pramipexole at 0.125 milligrams.
Can a combination of ropinirole and gabapentin be effective in avoiding augmentation?
Well, I guess the real crux to that question is, if you're on ropinirole and you start to have more symptoms, adding gabapentin would be a good idea instead of increasing the dose of Requip. So in that respect, being on both drugs would be helpful to maybe avoid further augmentation if it's occurring already, or possibly prevent it by keeping the dose low. But as we said before, even a low dose sometimes of Requip or Mirapex may be associated with augmentation if you give the patient enough time.
So after being off Mirapex, how long should someone wait to restart it?
I would say forever. Okay. In general, once you've had augmentation, it will occur pretty quickly. Now, when I say pretty quickly, I've seen augmentation return in 2 or 3 days. If you're lucky, it'll be a few weeks, sometimes a few months. Now, I do have patients who developed very severe augmentation with Mirapex or Equip, but for example, if we try to use opioids, after a week or two, they will develop constipation or some symptom that precludes them from continuing on that. So what I'll do on those patients is I will alternate the dopamine agonist like Requip or Mirapex with the opioid or whatever drug I want to use. And usually we can figure out whether the alternation should be a few days, a few weeks, a few months, depending on how fast it takes the patient to develop augmentation. And I have patients doing everything from 3 days on, 3 days off to 3 weeks, and sometimes even a month or 2 or 3. So depends on the patient, but typically I usually go from about 3 days to a week or 2 at the most.
Okay, I know you covered this, but it doesn't hurt to reiterate. Is it true that tramadol can cause augmentation?
Yes, again, tramadol is the only non-dopamine drug that causes augmentation. We don't understand why. It took us a little while to figure this out. I remember in some meetings we were talking among ourselves, the RLS experts, and we said, "Yeah, we've seen these cases. Seems to look exactly like dopamine augmentation." And then a couple of papers finally came out describing true dopaminergic, or sorry, true augmentation with tramadol.
All right. Does augmentation ever completely go away after stopping a dopamine agonist such as pramipexole?
Well, it's a very hard question to answer, and the reason being is that some people have been on pramipexole for 5, 10 plus years, and then we take them off, and the RLS will improve. And the goal would be to see that it improves back to where it was before you started medication. And that sometimes happens, especially on people who haven't been on it too long. But if you've been on the medication for 5 or 10 years, the RLS may have naturally worsened also. So you don't know whether the person's had some natural progression over that time. But we suspect that many people who have augmentation will improve off the medication, but there may be some irreversible augmentation changes that still stay. So they may lose 50, 60, 70% of the worsening, but not all of it.
All right. Does changing medications stop augmentation? And what are the withdrawal symptoms of getting off of a medication?
Okay, well, if you're talking about dopamine agonists, changing it to a non-dopamine drug takes care of the augmentation as well as you can. Um, Now, as far as stopping the or getting off, tapering off, or stopping a cold turkey, um, if patients are on low doses of the Requip or Mirapex, we just typically go cold turkey. Most patients don't have a lot of trouble, except that when you do that or even taper off, there is a marked worsening of the restless legs that typically only can be relieved by significant doses of opioids. So the big thing is withdrawal, is a recurrence of really bad symptoms. Mostly those really bad symptoms last only a week or two or three. Sometimes they can be longer. Uh, but usually the initial giving opioids at a higher dose, and then as the RLS gets better, you cut down to very low and reasonable doses. So that's typically what we see for these patients.
Have you seen augmentation occur with the use of methadone?
There's been an occasional article about could augmentation occur with some opioids, and there's some speculation about that. But truly, I don't personally think that there's any augmentation with the opioids. If we see some augmentation like problems, I suspect it may be due to some other issues like increased stress or even pain or anything else, like I discussed earlier, might cause worsening of symptoms. But we use so many opioids amongst the restless leg specialists that by now we would have seen a pattern. And remember, we have been doing this since probably 1990, 91 or so, and possibly earlier, but we've been using it for many, many years. So by now we would have seen this pattern.
How do I know if it is augmentation or I just need my dosage increased?
Well, if you heard what I said earlier, any patient who needs their dose increased, it's augmentation until proven otherwise. And if you go through the list of 4 or 5 things that I went over, um, such as triggers for restless legs and things that may make it worse otherwise, if it's not one of those, then it's almost assuredly augmentation. And frankly, even if it wasn't augmentation, it would not be a bad thing to think about getting off the dopamine agonist, because if it wasn't augmentation by then, it might be down the road.
All right. I have some mild augmentation from Mirapex, but don't find it necessary to change medications. Is this common?
That's actually pretty common, but the trouble is once you have some augmentation, it's kind of like the writing is on the wall that this is definitely going to get worse sooner or later. However, if you're on the medication and you feel you're doing well enough, I'd say there's no compelling reason that you have to get off of it, other than knowing that sooner or later you're going to do it. So what I often suggest to patients is, if you're having some mild augmentation, you're still doing, think it comes up, say, hey, I'm going to go on vacation, hopefully even an active vacation, and you want to try to get off then with a little help. When you don't have to worry about work and other things, it might be an appropriate thing to do. But if you want to wait till things get worse to bite the bullet, there's nothing uh, drastically wrong with doing that.
All right. I've had augmentation using Requip and then pramipexole. Are better drugs coming to market soon that won't augment?
Well, we're hoping, but there's some other new classes of drugs that may be coming out that should not augment. But after having said that in the past about other new drugs, like the longer-acting dopamine agonists, or even the short-acting ones when they replace Cinemet, we thought we knew what we were doing, and we found that we were wrong. So I would say there's some new classes of a new class of drugs, coming out that shouldn't cause augmentation, but until we have more experience, I don't want to speak too early.
Is methadone like other meds for RLS? Will it eventually stop working and or lead to worse RLS?
We have enough experience now with methadone and other opioids for treating restless legs. Again, since we've gone back to the early 90s, so that's obviously a lot of experience. And in most of my patients, I see little or no increase in the dose once we find an effective dose. And that's even accounting for the fact that we know restless legs often slowly gets worse over a decade or two. And, we're pushing almost, 3 decades of usage of opioids for restless legs, and we're still not seeing a dose increase. They had a big study at Johns Hopkins several years ago, and they found that the average dose change was about 5 milligrams over 10 years, and I see even less in my population.
Okay. Marijuana definitely helps my RLS. Will I eventually get augmentation from marijuana?
We don't know that much about marijuana because being a federally not legal drug, there's not a lot of research on it, but we are getting some more and more research, but not for restless legs. But being in California, I have a lot of personal experience with my patients with marijuana, and from the best I can see, there's no augmentation. It tends to work pretty well if inhaled. It does not work well when you use edible forms of marijuana. I've had some patients take enough edible marijuana to be high for 24 hours and really high and still suffer restless legs. When it's inhaled, you get very high doses that get quickly into the bloodstream, and you need very little, just a puff or two. But again, since I'm also a lung specialist, I'm not too eager to recommend putting anything in your lungs that doesn't belong there. But yes, it can help restless leg symptoms, but it only lasts a couple of hours, but it does work very well.
Okay. Other than changing medicines, what other solutions are available for management of augmentation?
Well, other than changing medications, which unfortunately is what usually needs to be done, the only other thing one can do is, if appropriate, give an iron infusion. And we actually have seen some patients with even augmentation do so well that their symptoms will go away. Some patients are so responsive to iron infusion therapy that they can even stop their dopamine agonists because they're good while their iron levels are up.
All right. Please address augmentation of RLS in patients with significant enough Parkinson's disease that stopping dopaminergic drugs is not an option.
Uh, this is a very interesting topic. We don't see as much augmentation in the um, Parkinson's disease patients who do have a significant incidence of restless legs, more than the general public. I've seen patients on Cinemet, which, as I said earlier, causes augmentation incredibly quickly and is the worst culprit of this. But even on pretty good doses of Cinemet, and oftentimes even combined PECs and other agents, and they don't seem to get as much augmentation, probably because they don't have any dopamine in their brain compared to RLS patients who have normal amounts of dopamine. We don't understand this fully. Now, again, I have seen some augmentation, and typically what we may do is maybe lower the dose a little bit, or if that's, and sometimes that's not appropriate because we need these medications to control the Parkinson's, I'll just treat around it and add opioids or the alpha 2 delta drugs if I have to.
All right. What are the pros and cons of tapering versus going cold turkey off 3.5 milligrams of ropinirole?
Okay, so in the paper that we wrote on augmentation, what we recommended is for lower doses, you can just go cold turkey. With higher doses, you want to taper. 3.5 is kind of a moderate dose, but getting to be high compared to what we see out there is what I'm referring to, not as far as what I recommend patients should use, because for me, 1 milligram is the max that I'll use for my patients. So typically, if patients are on, 1, maybe even 2 milligrams, I may not. I may go cold turkey. There's a syndrome called dopamine agonist withdrawal syndrome. You can see it sometimes. I see it very rarely, and actually, I tend to have most of my patients go cold turkey. If I see any funny issues with that, I can always quickly go back and say, okay, let's taper it. But when I get patients on higher doses, I will, and I've seen patients recently, for example, on 14, 16 milligrams or equip. That's just way too high. I'll taper off that. So really, it's a matter of kind of the individual doctor deciding what dose they want to taper from, or just go cold turkey. But what you want to avoid is getting some really bad withdrawal symptoms, and they can be, from horrendous restless legs, which can be controlled with opioids the majority of the times. But some people even get a little depressed when you do that, or other funny symptoms with like any withdrawal. But again, you have the choice of going either way. As I said before, most of the time I like to go cold turkey because when you taper, you kind of get a worsening every time you go down and you have to keep adjusting. So sometimes the suffering of doing that can negate any risk of just taking it off cold turkey and battling it for 1 or 2 days, and then you're pretty good. Okay.
Should you get off dopamine agonist meds if you are not showing augmentation after being on them for 8 years? And what is the best way to do that?
Okay. Well, again, if someone's on 8 years, has shown no augmentation, hopefully on a low dose, I'd say don't look for trouble. We can obviously wait till you have some issues. As soon as you start noticing, hey, symptoms are occurring a little earlier, or getting a little worse, I feel I need more medication, then we can tackle it. So I don't like to fix things that aren't broke, even though you're going to get augmentation. Or I can say not 100% of people get it, so maybe that individual will be lucky and not get it. And if you're going to get off, I would do it the same way. If you're on a low, I just recommended in my algorithm. If you're on a low dose, we can try a switch to a gabapentin, Lyrica, or Horizon, or maybe switch to Nupro patch. If you're on higher doses, then we might want to consider changing to opioids.
All right. What is the earliest you've seen signs and symptoms appear following initiation of a drug in question?
Well, if you're talking about augmentation, which I'll refer to, I
Mm-hmm.
have actually seen patients augment within 3-4 days. Or they just start the Requip or Mirapex, and their RLS within 2, 3, 4 days will go nuts. And I don't know exactly what's happening, whether that's augmentation or just some weird dopamine receptor function. I'm not sure, but there's a very small percentage that you give them the medication and they'll call you back within a day or two saying, I'm never taking this drug again. So that's the fastest I've ever seen. Uh, Again, usually you're talking weeks, months, or years.
All right. Will gabapentin become less effective over time?
Gabapentin tend to lose its effectiveness. The only issue you have is when doctors start increasing the dose, it may extra doses may not be helpful once you get above the 4, 5, 600 milligram dose, because most people don't absorb it that well at higher doses. It's absorbed in a very small area of the small bowel with very poor transporters. So giving higher doses uh, doesn't get all that much more in compared to the lower doses. So in that respect, it may seem like it's losing effectiveness because adding more medication won't help. But typically, whatever it does at whatever dose, it'll probably keep doing that indefinitely. It may have more challenges like the RLS getting worse due to augmentation or something else, and then it doesn't seem adequate.
Will I experience augmentation with all RLS meds if I experience it with one? If I stop it, can I use it again at a later date?
Okay, and I think we've discussed some of this, but I'll reiterate. Since it only occurs with the dopamine agonist and tramadol, if you've had one of those, it's hard to know whether the dopamine augmentation um, occurs with tramadol, because I've actually had patients who have had dopaminergic augmentation, and I've used tramadol later, and haven't had any trouble. But I will tell you, if you have augmentation from one short-acting dopamine drug, as I said earlier, you will definitely get it from another short-acting. Whether or not it will occur with a long-acting, we're not 100% sure. We need more time to look at that. But at the lower doses, you may be okay. Definitely at the higher doses of a long-acting dopamine agonist, if you've had it with the short, you'll probably get it sooner or later with the higher doses also.
Low ferritin levels are a known factor in the development of augmentation. Why is this? And is oral or IV iron best for RLS patients?
Okay, the real answer is we don't know why low iron makes restless legs worse and augmentation worse. We just know that high iron really helps it. We have some theories, and we used to think we were pretty smart on this one because iron is a cofactor in tyrosine hydroxylase, which is one of the rate limiting steps to make dopamine. But again, that's when we thought that dopamine was the only thing involved. It's much more complex, and we doubt that's the reason why iron really is necessary or helps. We're not really sure, but we just know that beefing up iron and even giving an iron infusion can be dramatically helpful. The issue we have with oral iron, which we still attempt, and some patients may do okay with that, but the issue you have when you have a low ferritin, let's say less than 5, which is very low, most people will absorb 20 to 25% of oral iron. When you get up to a ferritin level of 50 or 60, which is starting to become in the good range, your body produces something called hepcidin, which feeds back and tells the body, hey, this looks like there's a good amount of iron here, and it decreases the absorption, so you'll only absorb 2% or less. So you can see the diminishing returns as you get higher ferritin levels orally. You are unable to absorb as much iron from the gut, so you get diminishing returns by pushing it after that level. Of course, giving it intravenously bypasses that, and typically when we give it intravenously, we aim for doses between, blood ferritin levels between 200 and 300, which are a lot higher, and we feel that's a better level to drive it into the brain. But we've all noted patients who will not get symptomatic relief until they get levels even up to 130, 180. Dr. Early has one patient who needs to be above 250 on the ferritin in order to get restless leg improvement.
Okay, I've got a couple of questions related to sleep apnea. The first is, how common is sleep apnea and RLS, and does sleep apnea cause RLS?
Okay, well, you're talking about two common conditions. Um, Restless legs is 10% of the adult population, and you can look at the incidence of sleep apnea is somewhere, in the general population, minimum of 2 to 4% for the whole population. But if you look at men over 45, you're up to 15%. So these are two common conditions that coexist quite a lot. And here's the issue. Augmentation occurs much more readily when patients are drowsy or sleepy. So if you have sleep apnea and it's not well treated, not treated at all, you'll be more sleepy and you're going to have worsened RLS. So if I have a patient with both problems, I really, really want to make sure that I treat the sleep apnea successfully, so as to make the RLS treatment much easier.
Okay. My neurologist wants to do an electroencephalogram to see if I really have RLS. Any comments?
My comment is get a new neurologist because there is absolutely no evidence that an EEG has any relevance for diagnosing, treating, or have anything to do with restless legs. So if your neurologist isn't aware of that, if you're seeing him for restless legs, I suggest you see another neurologist.
All right. Are RLS and persistent genital arousal disorder related? I seem to have whole body RLS.
You know, people who have whole body RLS can also have it in the genitals. And another interesting thing is that even if it isn't in the genitals, this is something that I've seen and written about, and actually a South American doctor actually published this in a journal. He had a series of cases that orgasm can actually relieve RLS symptoms. So there is something that's involved, obviously, with the genitals and, uh, you know, uh, uh, what do you call it? Orgasm and everything that might have something to do with that. But the symptom, the other disease probably has nothing to do with restless legs itself, although some people were trying to correlate them. But I have to admit, I don't know too much about the other disease and whether it's some overlap with restless legs or not. I think they may have had a couple of patients who they thought had restless legs in that article, but they're probably two separate things.
Okay. With all the news about the opioid crisis, I'm afraid to even consider using them. How do patients do this safely?
Well, the first thing is you want to make sure you have a doctor who is very familiar with prescribing opioids, the doses that are acceptable and don't go on to dependence, tolerance, and addiction. And of course, these days it's a lot harder to get these drugs, so it's not as easy as it used to be. And we understand we're in the middle of an opioid epidemic. I would also refer patients to a free uh, download paper that they can get if you go on PubMed. You can pick up a paper entitled "The Appropriate Use of Opioids to Treat Refractory Restless Legs." If you type that into a PubMed search on the internet, on Google, you'll find it very quickly, and you can download it for free. A bunch of us wrote that paper and published it last year. And what we all describe is in the correct use of opioids to treat restless legs at the doses we use, it is very rare to see uh, tolerance, dependence, or addiction. So it can be done very safely and effectively, but you need a doctor who knows what they're doing and prescribes appropriate doses. And in the paper, we show the recommended doses. We talk about how to monitor it and follow the patients. So it can be done very well if you have a doctor who is somewhat knowledgeable or is willing to read the paper and is comfortable with prescribing these medications.
Is there a relation between MS and RLS?
There's a relationship between many neurologic diseases and restless legs. There's a higher incidence, and I'm not sure if this is because when there's neurologic things going on, they may have some overlap, they may be confused. I'm not sure there's that much of a true relationship with many of these neurologic diseases, but it hasn't been studied that well. I think we need quite a bit more study to be able to comment what's happening.
All right, well, that's the top of the hour, and I want to thank you, Dr. Buckfuhrer, for your time, and thank our audience for joining us. Our next webinar is on March 8th, featuring Dr. Winkleman discussing managing RLS with opioids. Thank you very much, and we hope you'll join us next time.